Good afternoon, everybody. Thanks for coming back so promptly. So we're going to start the afternoon session off. This is a series of talks on hepatology, and I think we've got some very pertinent and timely presentations lined up today. Our first speaker is Dr Dina Mansour. She's a consultant hepatologist from the Queen Elizabeth Hospital in Gateshead and has recently been elected as a section lead for hepatology for the BSG, and she's going to be talking to us about the burden of alcohol and what can be done about it. Thank you, Dina.
Thank you very much for inviting me to talk about this very important topic. I put this picture up because it's representative of the kind of flippant attitude to alcohol that we have in this country that really makes me angry. And it isn't part of the talk, but I just wanted to start off with a quick story because I was called a couple of weeks ago to give evidence in a coroner's inquest for a man in his 50s who had come into hospital and died about 24 hours later with acute severe pancreatitis secondary to alcohol. He had overwhelming sepsis, and the reason that there was an inquest was because his family did not want to accept the cause of death that was given. They felt that he had been discriminated against on the basis of the wrong assumption that he was an alcoholic, and that his care had been affected, but care had been withheld, and they didn't want anything to do with alcohol to be mentioned on his death certificate. And it just really brought home to me. So we went through the story. The paramedics went to his house, and it was covered in blood and feces. There was absolutely no food in the house. He had a grade 3 pressure sore. He had a glucose of 1.0. He told the paramedics he was drinking 500 mils of vodka a day. And I was called to give evidence because I looked after him for his alcoholic liver disease. And I'd only seen him once because he often didn't turn up to clinic, but he had seen some of my colleagues, and every time he came to clinic, he would say, "Yes, I'm still drinking. I really want to give up. I cannot. My mental health is too bad. I am too depressed. Please help me with my mental health." And we tried to refer him to CMHT, and I don't know if he was ever seen. But seeing that family, there was about 7 of them, all devastated, how it affected him, how it affected them. I just thought that absolutely epitomized the effect of alcohol on families, on society, on relationships. And although the family's wrath was misplaced because the team looking after him did everything right, he was failed. He was failed because it was cheaper for him to buy alcohol than it was for him to eat. He was failed because we couldn't join up his care to give him the mental health support that he needed. He was failed because there are so many opportunities to reduce alcohol consumption, and he was failed because the stigma attached to problem alcohol was such that he had to face it alone without telling his family. So I wanted to start off with that story because it really affected me, and I think it's a really good illustration. So I think the formatting of this may be difficult, but so we know that 1 in 4 people regularly drink more than the low risk alcohol advice of 14 units per week from the government, and we have over 600,000 dependent drinkers in the UK, and 82% of them are not in any kind of treatment. And the numbers in treatment has actually fallen by 20% since 2013, 2014. That's because of cuts to local authority funding. Alcohol is a huge economic burden on both the NHS and the economy as a whole. And admissions directly due to alcohol are rising, risen 8% since 2016 to 2017. But when we look at the alcohol admissions, the alcohol-related admissions, it's almost 1 million people being admitted to hospital with conditions related to alcohol consumption. That's almost 6% of all admissions. And although we haven't even started to see the effects yet on the pandemic, even in 2020, we'd already seen a 20% rise in alcohol-specific deaths. And it's really, really interesting to look at how alcohol-specific deaths are related to deprivation. So alcohol harm is absolutely mirrors inequalities in this country. So we know that the amount of alcohol someone consumes is related to their income. So the more someone consumes, the more money you make, the more alcohol you drink. And yet, you can almost exactly map alcohol-specific deaths onto a map of deprivation across England. And it is pretty disgraceful in the UK in 2022 that you are 7 times more likely to die an alcohol-specific related death in Blackpool than if you live in Bracknell Forest. And as I'm sure you're all aware, we just see the tip of a very large iceberg when we're looking after alcohol-related disease. It has the effects on mental health that we all know about. So 86% of people with alcohol-related problems have mental health problems concurrently. It's the biggest risk factor for death, ill health and disability among 18 to 49-year-olds in the UK. And it's a grade 1 carcinogen, second only to tobacco in its ability to cause cancer. And to give you an idea, even 1.25 units of alcohol a day, so that's 9 units a week, so that's low risk, increases your risk of developing liver cancer by 15%, increases your risk of developing bowel cancer by 7%, esophageal cancer by 25%. So even in small doses, it is a carcinogen. But as well as that, it has huge implications on relationships, on family life. Over 200,000 children live with alcohol-dependent parents. And in terms of crime, victims of crime report that the perpetrators were under the influence of alcohol in almost 40% of cases. So it's a big societal-wide problem. So what can we do to tackle it? Well, I think we definitely need a multifaceted approach, and we all need to work together. And the first thing that we need to consider is the change in culture and attitudes. And we have a really strange relationship with alcohol in this country in that we normalise and even celebrate excess alcohol drinking, whilst at the same time stigmatising those people we consider to have problem drinking. And we really need to turn that on its head. So those who are alcohol dependent have an illness and they need to be treated and supported as such. Meanwhile, we need to reduce the social normality of excess alcohol. And a lot of it comes down to policy. And I just mentioned this, I know there's not something we can do directly, but we all need to take responsibility for lobbying. I'm not suggesting for one moment that this government hasn't only got the best interests of everyone in this country at heart, but the alcohol lobby is incredibly powerful. And we know that the best way of reducing alcohol consumption and reducing alcohol deaths is to increase the price of alcohol. Alcohol has become 72% more affordable than in 1978. And the alcohol lobby don't want minimum unit pricing because 25% of alcohol revenue, a quarter of alcohol revenue, comes from 4% of the population who have the highest alcohol consumption. But the evidence for minimum unit pricing is very, very clear. Since it was introduced in Scotland in May 2018, consumption has gone down only in the highest drinkers, and they saw a decrease in alcohol-related deaths, whereas in the rest of the country, so England and Wales, alcohol deaths rose. But what can we do in primary and secondary care to help reduce the burden of alcohol harm? Well, we need to try and systematically identify those who are at risk and assess them appropriately. So we particularly need to identify those who have harmful or high-risk drinking and those who are dependent drinkers. And they won't necessarily present with alcohol problems. These people present with depression, anxiety, cognitive impairment, gastrointestinal symptoms, IBS, abnormal liver function tests, and that pretty much covers everyone in primary care. And we do know that screening in primary care is actually cost effective, but the government withdrew the incentives for GPs in 2014, unfortunately. And we need to think about when we're assessing them, not just the consequences of their alcohol, their drinking, but also the underlying causes for their drinking. So that includes mental health, that includes past trauma. A lot of these people are living lives that we can't imagine. And so that needs to be explored if we're going to be able to help them. In terms of screening, your initial screen should be an Audit C, and I'm sure you've seen this before. So this is a set of 3 questions that you can ask your patients to decide whether or not they need any further assessment or intervention. So if they score more than 5, then you need to ask the remaining 7 questions on the audit. If they have less than 5, you can just say, well done, that's absolutely fine, and not do anything further. But if they do score more than 5 and you go on to do a full audit questionnaire, you can assess their risk. I'm sorry, this hasn't come out very well on this projection, but an audit score of between 8 and 15 indicates an increasing risk. And those are the patients that you need to target for brief intervention. So, and those who have an audit score of more than 15 or who drink more than 35 or 50 units a week for women and men respectively, they need more than that. So you can do an extended brief intervention, but you also need to think about referring them to either CBT or to local alcohol services where they can get more support. That's when we need to think about things like a camprosate that might help with their cravings. And also importantly, we need to think about liver fibrosis assessment, and I'll talk a little bit about that in a moment. Those with an audit score of more than 20 are dependent drinkers, and they are the ones who may be at risk of alcohol withdrawal. There's a specific questionnaire that you can do to assess their risk of that, the Severity of Alcohol Dependence questionnaire. And they definitely need referral to alcohol services and may well need a formal detox. You also need to remember to counsel them on driving. So as we know, a lot of patients can be cagey about their alcohol consumption, and there are some clues in the blood tests when somebody may be drinking more than they are admitting to. And I'm sure you're au fait with these, but a raised MCV is often a clue, a raised gamma GT. When you do the secondary liver screen, if you include immunoglobulins, they tend to have a raised IgA. Their platelet count may be low, either due to bone marrow toxicity or due to portal hypertension, and their AST-ALT ratio tends to be raised, classically above 2. You can also do ethanol levels if you feel that they may be intoxicated at the time. So how do we go about organising a liver fibrosis assessment? And this varies from different parts of the country, but it's really important to do. So 75% of alcohol-specific deaths are caused by alcoholic liver disease, and they often present decompensated, and when they do, the mortality is very high. So it's really important to detect them early. And we've got various tools to do this with, and again, this has come out really small. You may have access to a blood test called the ELF test, the Enhanced Liver Fibrosis Test. In other places, we use transient elastography or FibroScan, and you may be able to request these directly from primary care. In a lot of areas, you still need to make a secondary care referral for this assessment. But also look out for incidental findings, which may give a clue that someone has advanced liver disease. So on the ultrasound scan, if they've got a recanalized umbilical vein or splenomegaly or a nodular-looking liver, endoscopy, they may find incidental varices. The blood tests, things like the low platelets, slightly low albumin, a bit of a raised PT that may give you clues. They often also have markers of malnutrition because they don't eat because they're drinking. And sometimes they have clinical signs. So in terms of intervention, so for those middle group, the ones that have an audit score of between 8 and 15, where brief intervention can be used, it's actually very effective. So people are twice as likely to moderate their drinking after they've been given brief intervention. And 1 in 8 will actually bring their alcohol right down to within lower risk levels. And that compares very favorably with smoking, where only 1 in 20 will listen if you tell them to give up smoking. And the basic structure of brief intervention, which should take about 2 minutes, is that you give feedback on their drinking. They say, I don't know if you're aware of this, but you are drinking at a rate that puts you at increased risk for your health, and you can give them some examples of the ways that it's detrimental to their health. You give the responsibility to them, so you say, you know, you need to take responsibility for trying to moderate your alcohol intake, but we'll be happy to support you with that. You give specific advice on how to do that, be that reducing the strength of the alcohol they're drinking, reducing the number of units on each day, or trying to get some alcohol-free days. And you give them a menu of choices, so not just one option, but different ways in which they could action it. And all the time trying to be aware that you must remain empathic and promote self-confidence, because oftentimes they are aware of the stigma that they're facing with their alcohol. And one of the things I think we are really need to improve on is joined-up care. So we really need to find ways between primary and secondary care of supporting people with complex needs, be that co-occurring mental health issues, physical problems, deep social problems, patients who don't attend hospital appointments because they are the very ones who most need to attend. And so I'd encourage you to have direct dialogue with your colleagues in secondary care, come up with joint pathways to manage these patients, and also NHS England have recently provided funding for alcohol care teams, which you may or may not know have been set up in various trusts across the country, and they should be liaising with you in primary care as well as with local authorities and alcohol treatment services to try and provide a more joint-up care for these complex patients. It's really important to engage the community mental health team, because so often mental health is the basis of the reason why people are drinking. And we really want to encourage an attitude that it's everyone's job, because one of the problems with these patients is they fall through the cracks and they end up as no one's responsibility. So in summary, next slide has nothing on my next slide. Alcohol is a big economic burden on the NHS. It affects families, relationships, and individuals to a high degree. We need a multifaceted approach, and we all need to work together if we're going to make a difference. Thank you.